Have you ever had food or drink go down the wrong way? It likely caused you to cough frantically. Remember how it felt when you were temporarily unable to breathe or felt like something has gone into your lungs? Unfortunately, this happens regularly for those who suffer from dysphagia. Dysphagia, or difficulty swallowing, can occur with food, drinks, or with both. Conservative estimates from international research indicates that approximately 8% of the population are affected by dysphagia. In hospitals, studies have reported dysphagia prevalence rates up to 71%, while in long-term care, 55% to 68%, and in the community, among older adults, dysphagia prevalence rate can range between 11 to 16%. Dysphagia is a symptom that often results from other health conditions. For example, neurological diseases such as stroke, Alzheimer's, Parkinson's, ALS, and dementia. Dysphagia may also be mechanical in nature due to abnormal growths or structural changes in the upper GI tract, inflammation, or even chronic gastroesophageal reflux. There may also be other underlying medical conditions such as diabetes, congestive heart failure, COPD, hypertension, and coronary heart disease. Dysphagia is also prevalent among individuals who are developmentally delayed. Signs and symptoms of dysphagia are diverse. Some key signs and symptoms may include physical signs such as choking, coughing, throat clearing, drooling, gurgly voice, food or drink going into the nose, runny nose when eating or drinking. A person with dysphagia may also experience difficulty with initiating a swallow or having to swallow several times after each bite or sip. You may also notice loss of food or liquid from the mouth or significant amounts of food left in the mouth after swallowing. And there may also be behavioral cues such as sudden or progressive change in eating or drinking habits, not wanting to eat or avoiding certain foods or drinks, or taking a long time to eat or drink. Dysphagia is often underdiagnosed and may be underreported because it is misconceived as an inevitable manifestation of aging or perceived as temporary because of illness. Attention is often diverted to the primary medical conditions reported by the patient, and the swallowing concerns are considered secondary. Your patient may not report the symptoms because they are embarrassed or unaware that treatment is available. If dysphagia is not properly managed or left untreated, it can lead to complications and consequences affecting the health and well-being of your patient. The discomfort and fear associated with coughing or choking, or the compromised ability to eat or drink may result in insufficient intake of food and drink, which can lead to dehydration and malnutrition. The embarrassment of chronic coughing, throat clearing, or eating too slowly may lead to a reluctance to eat meals in social settings, which can further lead to isolation and depression. Chronic aspiration of food, drink, and oral secretions can perpetuate chest infections and pneumonia, resulting in extended and costly hospital stays. In severe circumstances, airway obstruction, aspiration pneumonia, and asphyxiation can be life-threatening and may even result in death. As healthcare professionals, how can we help? A good place to start is by having a better understanding of how we swallow and what might go wrong. Let's look closely at how swallowing is supposed to work. Swallowing can be viewed in 4 phases. The first phase is called oral preparatory phase. When we put food or drink in our mouth, our lips, teeth, tongue, and facial muscles help to retrieve and contain the bite of food or sip of liquid. The food is broken down by the grinding action of our teeth and our tongue, and then mixed with saliva to form a cohesive, moist bolus for easy swallowing. The second phase is called oral phase. During this time, our lips are sealed and our tongue tip and posterior tongue elevate against the hard palate and the soft palate to contain the food or drink to prevent it from prematurely spilling into the pharynx or airway. When the bolus is prepared and ready to be swallowed, our tongue contracts and propels the bolus towards the pharynx. The third phase is called pharyngeal phase. In this phase, a number of physiological activities occur together in coordination to facilitate a functional swallow. For example, in this phase, the soft palate is elevated to prevent materials from washing up into our nose. Subsequent contraction of the tongue and pharyngeal muscles help to further propel the bolus while facilitating epiglottic inversion and laryngeal elevation to protect the airway and to prevent the bolus from going into the lung. In the fourth phase, called the esophageal phase, the bolus is propelled into the esophagus where peristalsis continues to move the bolus towards the stomach. All of these movements are finely timed and involve the coordination of many muscles and nerves, while they are carefully synchronized with our breathing, since we share a similar pathway for eating, drinking, and breathing. As you can imagine, if there is an impact on the timing, coordination, or movement, the swallowing function will be affected. To assist healthcare professionals and patients with the detection of dysphagia, several screening tools have been developed and are now in use. Here are a few examples. We need to understand that these screening tools are designed as minimally invasive evaluation procedures to determine the likelihood or presence of dysphagia. They often do not provide sufficient information to determine the specific swallowing issues to make recommendations for management or treatment. If the presence of dysphagia is determined, a referral to a dysphagia clinician, such as a registered dietitian, speech-language pathologist, occupational therapist, or other medical specialists for a thorough swallowing assessment is recommended. A dysphagia assessment may involve an examination of the following: oral motor function and oral processing abilities, cranial nerve function, respiration management and coordination, potential medication effects, mealtime management habits, posture and positioning, nutrition and hydration management, oral and dental health, and trials of texture-modified foods or thickened liquids. This examination can be performed at the bedside or at the tableside and will provide the dysphagia clinician with more detailed information in order to formulate and prescribe a treatment or management plan. In some cases, instrumental examinations, such as a video fluoroscopic swallow study or a fiber optic endoscopic evaluation of swallow study, may be used to better visualize the swallowing issues for more detailed diagnosis and to help determine treatment plans. So, what can be done for the patient? To date, the most common intervention prescribed by many dysphagia clinicians involves the modification of food textures and/or the use of thickened drinks. A recent systematic review of the scientific literature conducted by the International Dysphagia Diet Standardization Initiative indicates that thickening helps patients who aspirate. However, over-thickening is not desirable because residue can be left in the mouth and throat, which can be aspirated after the swallow. Other research has also shown that as drinks get thicker, they are less likely to be consumed, which can have an impact on hydration. The systematic review also indicates that there is no evidence which identifies a certain level of thickness or a certain texture is most effective to treat certain types of swallowing issues. The use of consistent terminology and simple, easy-to-understand testing methods are critical in helping our patients to ensure that they're preparing and receiving the prescribed food texture and drink thickness. This will ultimately improve patient care and safety. In addition to food and drink modification, a dysphagia clinician may also recommend mealtime management strategies, which may include moderating eating and drinking rate, optimal volume per mouthful, method of food and drink delivery, which may include the use of adaptive eating and drinking aids. They may also make recommendations around optimal head, neck, and body positioning to eat and drink safely and efficiently. Other recommendations can include oral care and secretion management, management of medication type, dosage, timing, and administration. In some cases, a rehabilitation and treatment program may also be prescribed to help strengthen and improve swallowing abilities. Ultimately, optimal management and treatment of dysphagia involves an interprofessional team approach with a focus on the patient while balancing safety, nutrition, hydration, and quality of life. As of today, dysphagia research is still in its infancy compared to some other medical conditions, and dysphagia remains a highly underdiagnosed and underdetected condition. Nonetheless, it is very encouraging to see ongoing research, new findings, and growing awareness for this condition driven by healthcare professionals and caregivers who are committed to the advancement of patient care for dysphagia. Let us all help to increase awareness about dysphagia and know that if properly managed, we can significantly improve the health and quality of life for those in our care who are living with swallowing difficulties.